And I would like to introduce you to André Krom. He's a senior lecturer at the Department of Healthcare Ethics and Health Law at Leiden University Medical Center. And previously he was involved in the Horizon 2020 Integrity Project, focusing on developing teaching programs and tools aiming to qualify students in responsible research and to stimulate critical awareness regarding integrity issues in research practice. And according to Mariette, he's a real hands-on ethicist. So let's see how hands-on it is. So I wish you good luck and thanks.
Thanks. First of all, it's Mariette, first of all, it's a real honor and a pleasure to be here. So thank you for inviting me. To be honest, I'm somewhat skeptical and ambivalent about the whole measuring all sorts of things, because often I think we do not really know what we measure. So I kind of like the Wittgenstein-inspired question earlier. So, and I'll tell you a little bit about my ambivalence and also, well, sometimes also skepticism. I'm supposed to talk about medical ethics education. I will do so, but I will start with a model that Mariette and I developed, because this is when my ambivalence and skepticism began. So we were on a journey, and Johannes talked about it this morning, to figure out what is known about what makes responsible conduct of research education effective. And we tried to develop a model. It's still a prototype tool in Excel, trying to summarize everything that is known from meta reviews about what makes this type of education effective. And the more and more we worked on it, the more and more I thought, what is this about? What do we measure? Is this at all predictive of effective education? And I had my doubts, and I think Mariette as well. And these doubts still continue, even after the work that Johannes presented this morning, because Mariette and I were involved in this as well. So this is a starting point for my talk. It's a prototype in Excel. I won't go into the details, but well, it's really a first draft. It tries to summarize everything that is known from the literature. The study that was done by Johannes and colleagues is not included, but, well, it could be included. So basically, this tool gives you some information on how you might improve the quality and effectiveness of your responsible conduct of research education. And it promises that you can find relevant information in 3 clicks, maximum. And this is what the first click will show you. This is what I call the central station of the model. It's an overview in which we well, divided common topics in the literature into 3 categories: input, process, and output. So you put something into education, you have an educational process, and there's some output in terms of learning aims, for instance. The second click, you will have the option to choose a topic, and then at the third click, you can look at the main lessons known from the literature, or you can have a look at the underlying details. And this is just an example. There's much more. So, for instance, the literature says, well, if an organization advocates instruction in responsible conduct of research education, your research will be more effective than when the organization does not advocate instruction. What we find was really interesting is that there was no information whatsoever on the effect of the research culture on the extent to which the education is effective. Now, when Mariette and I talked about today, you asked me, is there something like this for medical ethics education? And my answer was no. On second thought, maybe, and I will talk a little bit about this. And so if there's not such a model yet, could it be useful to have a model like this? And I think it could be, but I think it's important to always put the evidence about the effectiveness into perspective. And we heard during the earlier discussions many, I think, very relevant points that we need to consider when you look at the evidence, what exactly does it say? So for instance, the example that Johannes gave this morning of the serious gaming tool, it had a large effect size and compared to other longer lasting courses. Now this is impressive, but we do not know whether this effect size lasts over time. So it might be that something that is really effective in the short run might also dissipate very quickly. So it might turn out that something that looked less effective in the first place might be more effective in the long run. But we don't know. So that's the first reason to be cautious when interpreting this kind of evidence. I think we should always talk primarily about the quality of education and not so much the effectiveness of education. And of course there's a relation, because the extent to which your education is effective in promoting specific learning aims is of course a key part of the extent to which your education is of high quality. But we should be careful not to reduce quality of education to its effectiveness. And this might happen in an instant without our even noticing it. So I think a basic quality criterion is that learning aims should come first and assessment should follow. For instance, it might be more effective to provide medical ethics education to males, but of course it would be absurd to draw from that the conclusion that we should primarily or only educate males. In medicine, for instance, this would be absurd. And now, while this may be a silly example, I think the point it expresses holds more generally. I think this goes for every outcome that you find in the literature. Johannes said this morning, case discussions might not be the gold standard. Okay, but still, in a specific professional context, it might be necessary to make use of case discussions, and I think medicine is a great example of this. And this has to do with the way medicine is organized. So people have to come together in groups to decide on specific cases what is good care in this instance. And it makes sense, I think, to, even though case discussions might not be the gold standard, to use them anyway, even if we know there are other methods that might be more effective in some sense. Another example, some methods might be more effective than role play, but still, role play might be the best fit for the specific context. And I think, again, medicine is a good example. So these are just a couple of examples to show you that even while we might know what is more effective, we might have very good reasons to choose methods we know to be less effective. Okay, now, and I think the list goes on and on. More generally, there will probably be trade-offs between what is most effective, on the one hand, but also what is most important pedagogically. So what kind of aims do we have in mind when developing our education? And I think it's important to always make clear what kind of trade-offs these are. And sometimes I think it might be, we might have very good reason to go for the less effective option because it fits the specific context in which we try to educate people the best. So some characteristics might be essential components, even if we know them to be less effective. And again, I think using case discussion in medical ethics education is an example. I think there can also be practical constraints. So sometimes when you read the literature, they talk as if we have all the money in the world, all the time in the world. But of course, this is often not the case. And I think practical constraints are really relevant in determining what we can exactly do for this money and how to best invest this money. And I'm not sure if reflecting on what is the most effective method is always the best way to spend our money. It might be, but it might not be. I think there's good reason to resist the temptation to adjust our courses along the lines of what enables us to score better. For instance, we could put more focus on knowledge transfer just because it's easier to retain. But it might be that it's not the most important aim in the given context. This could yield more effective medical ethics education, but also of a lower quality, because, of course, knowledge is important, but not perhaps the most important thing. So this is the intermediate conclusion. I think there is a legitimate place for evidence about what contributes to effective medical ethics education, but only within the boundaries of important learning aims. Back to Mariette's question, is there something like this for medical ethics education? And I said no, and I think maybe. Because there are some studies that are included in our quality checklist that I started with that were excluded from the meta-review that Johannes and colleagues did for the main reason that they focused on medical ethics education and they were not about responsible conduct of research. So there is scattered throughout this model all sorts of relevant information, I think, about what might contribute to effective medical ethics education. So here's an example. So this is one study that was excluded from the meta-review that Johannes mentioned, but it is included in this model. So here, for instance, you see well, how effective specific education was when you look at different age groups. Here's another example. So focusing on ethical domains, ethical behaviors, and ethical standards might not be effective generally or in the context of responsible conduct of research, but it was so in the case of medical ethics education. So there might be a difference between different disciplines, what makes for effective education. Now here are some other examples that I'll skip. Even if we think that there's a legitimate place for focusing on evidence about what makes effective education, I think there are additional reasons to put this evidence into perspective. For instance, can we measure everything considered to be important from a quality perspective? And I think the answer is no. So suppose you are having a case discussion with a group of people about the doctor-patient confidentiality, and this case involves a spouse that has cheated on the other one, but does not want to tell his or her partner. Now, suppose that the teacher makes all sorts of difficult remarks concerning or directed at specific students that constitutes an unsafe learning environment. Now, there are two scenarios. So one scenario in which you know that this happens, and another scenario in which you don't. And of course, the latter scenario is relevant as well, because if you have a pre- and post-test, and for instance, it turns out that your education does not seem to be effective in promoting certain learning aims, the cause might be that the learning environment was unsafe, but this is not something that you have taken on board in evaluating whether or not of what makes for effective education. So how do we know what conclusions to draw when there's, for instance, no change in measured outcome? There might have been some factors driving you downwards, others driving you upwards. The end result is the same, which might well, enable you to draw the conclusion, well, we did not manage to do better, but perhaps you did better in some respects, but you just don't know, depending on what you measure. And so the example of a safe space is, I think, an example of this. So to recap, and I think we're almost out of time, I've shown you a model to improve quality and efficacy of RCR education. And I gave some examples that it does include relevant information about what makes for effective medical ethics education as well. I've provided some reasons to put the focus on evidence in perspective. I argued that maintaining a primary focus on quality of education instead of effectiveness is really important, and that we should be careful not to reduce quality to matters of efficiency or effectiveness. And I gave some examples to show that even if other approaches might be more effective, there can be solid reasons to prioritize approaches known to be less effective anyway, assuming that we can measure everything that contributes to quality, which I'm doubtful about. So there is a legitimate place for evidence about efficacy of medical ethics education, but only within the boundaries of important learning aims. Otherwise, we might end up with medical ethics education that is really effective, but also of rather low quality. Thanks.
Thank you so much. A very nice bridge between integrity and ethics. There's room for, I think, one question or two really small questions. Oh, it's not working. Yeah, Julia.
So thank you for this really interesting talk. It hits my field of expertise, not medical education, but measurement. So my question is, who is going to decide how high quality we have in the classroom? And combined to this, do you think it is a measurement problem, or do you think it's not to be measured? So these are two.
Yeah, and I'm not sure if I can answer either of your questions. So with regard to who decides, I just don't know. But I quite liked what was said this morning. So talking about what makes you tick, reporting back. So for instance, Dorothea, we work together in the same department. We often talk about our education. So sometimes you have a nice story about something that worked or seemed to work. It's not evidence in the sense that we talked about this morning. But so, to me, in an attempt to answer your first question, I would say that this is something that should be at least organized. So talking about what you think adds to effective medical ethics education. But I'm not sure if you end up then with the evidence that you would like to have. So this is my attempt to answer that question. And to be honest, I forgot the other one. So could you repeat? Is it
a measurement problem in a sense of that we don't know how to do it, like social science measurement problems, or is it not to be measured?
Yeah, it could be. But so I was quite impressed about certain articles in the literature that said, well, for instance, so what you would really like to have as a result of medical ethics education is a good doctor, right? Also good in the ethical sense. But it's almost impossible to organize a process in which you can test what really contributes to effectiveness or good quality also in the ethical sense. So it might be that we can develop some measurement methods that will do better than the ones we have now, but I'm not sure whether we can really devise a test that can really answer your question. So to know exactly 100% that which factor contributes to what. I think it's an illusion. Doesn't mean that we shouldn't try, but I think at some point it might be that it will take so much effort that then the question arises whether it's worth it or not, or whether we can do with less time-consuming, money-consuming processes that can also help improve the quality of our education.
Thank you so much. I think we have to leave it like this. It's a surprise, but I have a present for you.
Okay.
Too late. Thank you for your talk.
Thanks.
And good luck.
Dank je wel.